Good afternoon. So we should go ahead and start. I know some of our audience joins us just a little bit later, but I want to make sure we have time for discussion before everybody has to go again. I also remind you that this is a room that has very good acoustics, so if you have to leave early, actually I would really strongly recommend that everybody at least stay till we finish the questions period so that we don't disrupt the presentation. But if you by any reason have to leave early, please try to do so quietly. If you have to type on your computer, also please try to do so quietly. So I'm really happy to welcome you to the second of our seminar series this quarter. Last week's was exciting, and today's will be even more so, in my opinion. Most of this seminar series, we get nominations for distinguished speakers from different parts of the country, sometimes different parts of the world. And it's really a privilege that we get to hear from them. But we also greatly appreciate those who nominate speakers. These seminars are recorded, as you know. They're archived through the UC Online Open Coursera program, and we thank the Office of Extension for that. So we know that long after we're done here, the impact of the presentations continue to grow. Today's speaker was nominated by Professor Dina Mokamel, and she's a distinguished member of our faculty in public health. Her primary appointment is in the School of Medicine, and she's also affiliated with the Health Policy Research Institute. So I'm going to turn over the podium. I'm not at the podium, so Professor Mokamel. Most of you don't know her until you have to take a course in health policy. But this is a good opportunity also for you to know who she is, meet with her, talk with her, hopefully, if not today, sometime in the future. So please help me to welcome Professor Mokamel.
Thank you. Well, it's my great pleasure and privilege to be here with you today, and a wonderful pleasure to and privilege to welcome Dr. Helena Temkin-Greener, who's not only a good friend but a collaborator with whom I've been working for probably 20 years now.
Please proceed.
Okay, I'll try to speak louder. Dr. Helena Temkin-Greener is a nationally known expert on this topic of team performance, in particular in healthcare. She is a professor of public health sciences and the director of research in the Center for Ethics, Humanities, and Palliative Care at the University of Rochester Medical Center. She also has an appointment at the School of Nursing there. And she holds a PhD in anthropology from the University of Massachusetts Amherst and a Master of Public Health at the University of Rochester. She has a large research group there and a large number of PhD students, and was also the director of the program, of the PhD program in health services research and policy, as well as the postdoctoral program there. As I said, Dr. Helena Temkin-Greener is a national and international known expert on issues related to long-term care and the elderly. She's done a lot of work on developing outcomes, risk-adjusted outcomes to measure quality of care, and has done a lot of work on teams in both hospitals and long-term care community and institutional long-term care settings. She has developed measurement tools to measure team performance and has used those to understand how teams perform and how the performance of those teams influences the well-being of patients. So I'm going to stop her and have her share her knowledge and wisdom with us. Helena.
Good afternoon. I don't think this is working, but can everybody hear me? Yes? Okay, great. Okay, great. This was a wonderful introduction. I would have traded it, though, for a few degrees higher temperature. But, that's my wish. Anyway, you do study in a beautiful place. I have no idea how you can concentrate here. But I will try to concentrate on the topic today. So I wanted to talk to you about healthcare and teamwork in healthcare. And often when we talk about teams and teamwork in healthcare, we talk about it in practically the same breath. One could actually use a sort of an old-fashioned analogy of a horse and a buggy, and that's teamwork in healthcare delivery. At least that's the perception in the minds of many healthcare providers and policymakers, that those two are always going together. And indeed, if you look at the literature, assertions about desirability and relevance of healthcare teams has been very common, both in the professional literature as well as in popular literature, for decades, actually close to a century. Really, there have been mentions of teams and teamwork in healthcare. But the empirical evidence as to whether teams and teamwork really exist, or whether, even more important, whether they matter with regard to performance of organizations or patient outcomes, that evidence is quite scarce. And that's really what I want to talk to you about today. I want to talk about what are teams and teamwork, what do we know about their impact on organizational performance and on patient outcomes in particular. And I will, of course, use a lot of examples today from my own work, which was largely done with Professor Mukabal's collaboration. And if I happen to use, in healthcare it's a whole different language, and we use acronyms. It's like a whole alphabet soup. If I use an acronym and you have no idea what it is, feel free to just raise your hand and I will try to clarify. The question is, how do I, Okay, so part of the problem in studying teams and their effectiveness is that everyone has their own perspective on what makes a team. And there's really no single agreed upon definition as to what teams are. So one definition that's offered here comes from organizational literature, and it defines teams as a collection of individuals who perform tasks that are interdependent, they share the responsibility for the outcome, and most importantly, they see themselves and are seen by others as an intact social entity. If we are to measure presence, whether the teams exist or not, we also need to sort of understand what makes a team work. So how do we measure? We can measure teams. We can ask people, do you work in a team? Do you see yourself and are seen by others as a social entity? But what is it that you do? How do we measure that? So one way of looking at teamwork is as a relationship between two or more health professionals who provide patient care and who work interdependently, who share common goals, who view patient care as their common goal, who are seen and can testify to working collaboratively, and who share information that leads to shared decision making in the process of providing care. So among benefits that have often been claimed for teams are things like teams result in reduced staff turnover and absenteeism among healthcare workers. Teams provide higher motivation for staff. Teams reduce staff conflict, improve financial outcomes, increase quality of care. So we've seen a lot of these assertions, and they have really been largely throughout those 100 years that teams have been bandied about, assertions rather than empirical evidence. But given the benefits that are proclaimed for teams, it isn't really surprising that there have been repeated calls for team approach in healthcare, and that this repeated call has come from some very important organizations. So just as it doesn't work. Yoo-hoo. Oh, I'm pressing the wrong button, sorry. It will work. I don't work. So already, as far as back as some 30 years ago, in 1978, IOM recommends teaching the team approach to care delivery in medical school. This was for the first part emphasized to be taught in medical schools. This was quickly echoed 2 years later by the American College of Physicians, supporting the IOM recommendations, and the same year the American Nurses Association also identifies collegial and collaborative joint practice as an ideal approach to both education and practice. Then again in 2000, IOM recommends interdisciplinary team approach, and that comes from the fact that healthcare is inherently interdisciplinary, and people who come from these very diverse disciplines do not naturally work cooperatively with each other. They don't have the common language, so teaching the team approach was recommended across disciplines. In 2003, IOM reports insufficient presence of teamwork. In 2005, the Commonwealth Funds asserts there is lack of coordination and attributes this lack of coordination to insufficient teamwork. And then in 2006, the Agency for Healthcare Research and Quality launches a new model called Team Strategies and Tools to Enhance Performance and Patient Safety, or Team STEPS in short. And this model was actually developed years ago by the Department of Defense. And then the HRQ has worked with Department of Defense to take a model of team implementation that was used in the military very effectively. In the military, you can imagine, people really need to work in teams, or the results won't be very good for anyone. And so HRQ partnered with DoD to develop this model. There are now several types of team steps. They started with the hospital-specific team steps and most recently launched this year, actually at the end of 2012, a model for nursing homes. So there has been a lot of discussion about teams are good, do they exist, what do they do? Just about a year ago, AHRQ completed a very large hospital survey on patient safety culture. They surveyed over 500,000 staff working in hospitals, in over 1,000 hospitals, and the results appear to be good. 80% report strong teamwork within units. Of course, that is only good if you believe that teamwork is important. So 80% report strong teamwork within units. But all is not well in paradise when they also report that Things fall between cracks when transferring patients, 40% reported that. Important information is lost during shift changes, over 50% reporting that. Problems often occur in exchange of information, and units do not coordinate well with each other. So, how does that really align with strong teamwork within units? It's a little bit questionable. When you dig further into this, as I did, here is a study titled "What Do We Know About Healthcare Team Effectiveness?" It was a large review of the literature, a meta-analysis of literature going back to 1985. They retrieved a massive, almost 2,000 citations that had to do with teams in healthcare. Out of these almost 2,000 citations, they only identified 34 studies that were empirical studies, that were based on empirical evidence. And only 29 of those actually involved care delivery teams. There are many teams in general. There could be management teams, there could be quality control teams, there could be care delivery teams, and apparently there's much less attention on care delivery teams, and that's really my interest and my focus, because it is the care delivery teams that produce the outcomes with regard to patient care. So this study concluded that to date, this body of literature has failed to demonstrate conclusively that the use of teams will enhance patient or organizational outcomes. Not a very positive conclusion. Yet, and if you are confused, that's okay, because that's the plan for now, is for you to be confused. Yet, at the same time, there exists a general perception, perhaps even agreement, by some very powerful people and powerful organizations that team-based approach to healthcare provision is already widespread. Not that it's good, but that it's widespread. So here is a citation from the Robert Wood Johnson Foundation, which reports that 97% of U.S. healthcare organizations report using team-based approach in delivering care. That's based on a survey. 97% of healthcare organizations report team-based approach. Just 2 years ago, the Undersecretary of Health for the Department of Veterans Affairs said, "We are creating a healthcare system that is first and foremost patient-centered and characterized by team care." And from our neighbors to the north, where the weather is actually warmer than in California, a minister for, the Deputy Minister for Ontario Department of Health said, "Team approach is fundamentally transformative. It will change the nature of health delivery in a very positive way." So who are we to believe is the question. And what is the reality of teams and teamwork? So I found this neat little clip about our neighbors to the north. Canadians are right now putting a huge amount of money into the national development of healthcare teams everywhere, all throughout Canada. And so this is about that.
It seems clear that these stroke survivors and their carers benefit greatly from their Friday morning dance class. What's less clear is whether the teamwork approach being championed in this stroke unit and now right across Canada is also beneficial.
There is mounting evidence that teamwork can improve patient outcomes in terms of morbidity and mortality.
At the moment, there's very little evidence for the effects of teamwork. If teamwork was a drug, it would not be licensed in any country.
Despite debate about the quality of evidence, Canadian governments are now spending tens of millions of dollars promoting teamwork in healthcare, with the hope that patients and professionals will be the winners.
I think this is fundamentally transformative. I think when you can truly move from a series of siloed professionals working in parallel towards a common or an uncommon goal to an integrated, functional team, you will change the nature of healthcare delivery in a very positive way.
She's able to.
Okay. So despite these largely mixed messages, there continues to be enthusiasm for teams and teamwork, and enthusiasm is not really diminishing, despite an occasional skeptic that believes that if it were a drug, it would not be approved. And the driving force behind this continuing interest is the challenge of coordinating increasingly complex patient care due to a very highly specialized nature of medical care. So imagine being this patient in the middle here and having to interact with all of the people in this maze, and not you just interacting with these people, but these people interacting with each other. And so, for example, a typical patient with diabetes may see typically 8 different physicians from 5 different types of medical practices. And the complexity and fragmentation of healthcare make coordination of care particularly problematic. And it is coordination that has been identified as one of those work processes that present a special challenge in healthcare, and whether or not it is team-based, but it is hoped that teams, when they are effective, will promote better coordination and the work processes that lie behind it. Studies have focusing on work processes, and work process improvements are not just in healthcare, but they also are thought of in other high-risk industries. And these studies have typically focused on the relationship between coworkers, which shape the communications through which coordination occurs. So these studies suggest that as relationships between coworkers share goals, as coworkers share goals, they share knowledge, and they share mutual respect, so will communication become frequent, more timely, accurate, and problem-solving. The reverse, of course, is also true, and that is that as relationships become more functional, have more functional goals, knowledge becomes exclusive to one discipline, and it does not get transferred either to the other discipline or doesn't trickle down hierarchically from team leaders to team workers. That does not promote respect between people, and then communication will in turn become infrequent, delayed, inaccurate, and there will be a lot of blaming going around. So that's sort of the theoretical framework behind why better work relationships promote better communication, which in turn promotes better coordination. So for the rest of the presentation, I would like to focus on the relationship between teams and teamwork and patient outcomes, and some empirical evidence that comes from the existing literature and from our own studies.
Can I ask a question?
Yes.
Before? So the network that you showed, the participants within the team, before you showed that, I was thinking, okay, part of the reasons that people have different opinions is probably because the membership of the teams are not standardized. And I could imagine additional participants in the network you showed, or maybe fewer. How standardized are the memberships in all of the studies that have been?
Well, that's part of the problem. Part of the problem is the lack of even a definition of what is a team. How many people are in a team? Is it a team that is designed by the management, or is it a team in which roles are specified and the team meetings exist, or is it a team that sort of rises spontaneously because people feel the need to collaborate with each other? And part of the problem might be is that, unless you define specifically what you mean by a team, what kind of a team it is, you can't really measure it. Right? So it's a good observation. Thank you. Okay. Teamwork and patient outcomes in acute care hospitals. So this, one of the very first models of teamwork in acute care hospitals was developed by Steve Shortell and his colleagues. And they developed an analytic model for performance in intensive care units. They basically said that all things being equal, given the same technological availability of technology and patient risk factors and nurse staffing, that how people interact, what we have in this box called caregiver interaction, is going to influence performance within ICU. And they created scales for measuring of these caregiver interactions, scales for measuring like leadership, communication, coordination, problem solvings. These scales are like Likert scales. They are basically a bunch of items on a scale. The scales that they used was 1 to 5, with 1 being, I least agree with it, 5 being most agree with it, and a number of measures that are focusing specifically on leadership, a different number of measures focusing on communication, and so on. And then they looked at the relationship between those measures and performance, and they looked at 2 kinds of performance factors. One called objective factors, which are risk-adjusted mortality, the ultimate outcomes, right, we're all interested in. The other one was risk-adjusted length of stay, which is not really an outcome the way health services researchers define it, but we'll let it go for now. And a set of self-evaluated outcome. By set of self-evaluated, I mean they asked staff to evaluate their ability, their technical quality, their ability to provide technical quality of care, and their ability to meet patient and family needs. And it's my friend Dana.
My apologies.
Okay, so what did they find? So they had data on over 17,000 patients in 42 intensive care units in 42 hospitals, and they conducted surveys with over 1,400 team members. So the team members were RNs, MDs, and others who work together in an ICU. They did not find the association between caregiver interaction, between any of these, I want to show you with my finger, but that doesn't work, between any of these domains of leadership, communication, coordination, and mortality, which actually is probably good that they didn't, because it would be real trouble if leadership contributed to worse, higher mortality. But they did find the relationship with risk-adjusted length of stay. So better caregiver interaction, lower length of stay. They did not examine other outcomes other than mortality. Okay, then more recently, Jody Gittell, who is a professor of business at Brandeis University, focused on those underpinnings of teamwork that she refers to as relational coordination. This is basically, she says, those relationships such as shared goals, shared knowledge, and mutual respect. This is very similar to what Shortell was measuring in terms of, it still focuses basically on communication and coordination in terms of communication, frequency, timeliness, accuracy, and decision and problem solving, and in terms of coordination, shared goals, shared knowledge, and mutual respect. Gittell's original work, interestingly enough, was not in healthcare. She was interested in airline industry, and she focused on flight departure process. Her original study included sites, airlines from such as Southwest, United, American, and at each of these sites, employees in 5 functional groups were surveyed. So ticket agents, gate agents, baggage handlers, ramp agents, whoever. They were surveyed about their communication and coordination and relationship with each other, and with pilots, flight attendants, mechanics, cargo agents, cleaners, fuelers, you name them. And she also measured quality, or what she called quality or efficiency, and this was measured by customer complaints, mishandled bags, happened to everyone, so we can really empathize with that, late arrivals, as well as gate times for departures and so on. And interestingly, she found a very strong relationship between how well these units of airlines did in terms of relational coordination, so higher relational coordination, higher quality and performance. And I was very pleased last year because just about this time last year we got Southwest flying, so now we have the best too. So that was my breaking news for the day. Okay, but Jodi Giroux moved on further, and she actually did look at the impact of relational coordination on medical performance. In this study, she examined the association between coordination and medical performance measured by length of stay, cost, readmission rates, and mortality. And this study was conducted among 52 physicians and about 6,000 patients. And similar to Shortell, she found no relationship with mortality. So there are no stars here for significance, but there was a relationship with length of stay. So for every point increase in relational coordination, patient length of stay was reduced by 2/3 of a day. And cost was reduced by about $670. And the likelihood of readmissions was reduced by 60% for readmissions that occur within 7 days, and by 69% for readmissions that occur within 30 days. So these are really very significant effects. And the interesting part behind all of this, and why I'm interested in measuring the relationship between teams and teamwork and outcomes, is because these are things that are modifiable. You know, there are many things we can't modify, so we can look at a relationship between, bed size in a hospital or a nursing home, or whether the nursing home or a hospital is for profit. But we're not going to go to a manager and say, you know what, you'd be doing much better if you were not for profit, but you are for profit, so tell your investors off and change your profit status. It's just not going to happen. But if we can advise them on how to implement better work processes in order to help staff to work better with each other, and that will translate into patient outcomes, that's something rather cool. So I want to turn now to the studies that actually Dana and I have been conducting in 2 settings. First, we looked at the relationship of teams and teamwork in the program of all-inclusive care for the elderly, called PACE. This is a nationwide program for frail elderly who are nursing home certifiable but who choose to live at home. And actually the first such site was established in California in San Francisco. PACE is capitated, and it provides a very comprehensive spectrum of services, basically ranging from primary to acute to institutional. And PACE is financially accountable for all those services. It is really a prototype of what perhaps the Health Reform Act of 2010 wants to promote with regard to the accountable care organization that presumably will be developed all throughout the United States. And the second set of studies focuses more on nursing homes. So we used the model that we actually adapted from Shortell to examine the impact of similar teamwork domains on resident outcomes in these two settings, in PACE and in long-term care, institutional long-term care. And our main focus was on the relationship between staff cohesion, which is defined as group, having common group identity and common goals, on risk-adjusted outcomes, and then perceived work effectiveness, which is again the same as I explained when I was talking about Shortell, perceived technical quality and perceived ability to meet residents' needs and risk-adjusted outcomes. And well, I think that's coming up in the next one. But what we did first is we first tested the reliability and validity of this survey tool. We did it both with regard to PACE and again in 2009 with regard to nursing homes. And the results that I present here are with regard to PACE. And we conducted, at the time that we did this study, there were about 26 PACE programs across the country. Today there are 88, so it has grown quite nicely. And the study was based on these 26 programs and on surveys which we obtained from 1,220 workers in the PACE programs. Again, we used these Likert scale to measure leadership, communication and coordination, and conflict management, as well as staff cohesion, with a 5-point Likert scale, with 1 being the worst, 5 being the best. And for a 1-point increase in communication, the results demonstrated that there was an increase of almost 3/4 of a point in team cohesion. So you can see here, better communication, better team cohesion. Conflict management and leadership were also important, but not as important as communication. With regard to assessing the impact on perceived work effectiveness, we found that communication was also the most important single predictor, with 1 point increase in communication leading to almost 0.5 point increase in work effectiveness. And so these findings suggest that if you are to prioritize team building activities, communication and coordination should be the first area to address. While leadership was less important, as was conflict management, it may be an artifact of the analysis, because if good leadership leads to better communication, then the effect of leadership that we are showing here is the residual effect that is above and beyond its impact on communication and coordination.
So staff cohesion and perceived work effectiveness were written constructs, or you measured them directly, independently?
No, these were constructed within the survey, and they were reported, right? So we are first measuring the relationship between these constructs and what is important, and then we're moving to outcomes. But both staff cohesion and perceived work effectiveness can also be construed to be measures of organizational performance, right? I mean, if your staff feel that they are more cohesive unit, that's good. We now want to see whether that means anything in terms of patient outcomes. Okay, so then, thank you for the introduction to this slide. Then we are actually looking at the perceived team effectiveness, which is assessed by staff, and patient outcomes, which is assessed by clinical information. Completely different. So here we examined change in outcomes at 3 months after enrollment in PACE and at 12 months after enrollment in PACE. And with regard to functional status, we see that patients in programs with better team effectiveness experienced a 0.71 less decline in activities of daily living limitations at 3 months, and within 12 months they experienced less decline in 1.7 activities of daily living. So remember, this is a population that's of very sick elderly. We don't really expect them to recover from whatever functional disabilities they have, but we would expect that with good care they will be declining at a lower rate, and indeed that is what we are seeing. Better perceived team effectiveness, less decline at 3 months, and even more less decline at 12 months. With regard to urinary status, we see a decline at 12 months, but not at 3 months. That's why it's under the arrow. It's just my way of sort of reminding myself what that means, as opposed to over the arrow. So that means that within 12 months, patients in the program with better team effectiveness had 77% lower odds of decline in urinary incontinence. And we found, similarly to Shortell and Gidrell, no association with mortality. Okay. Any questions so far? No? Okay. So then we moved to nursing homes. We wanted to basically see whether we can see the same relationships between better performing teams or better teamwork and nursing homes. Now, some teams are actually mandated in nursing homes. So all nursing homes have to have a care assessment and planning team. So we know those exist. We know that a number of nursing homes have wound care teams. They are not mandated, they don't have to exist, but they do. But what we were really interested in, whether workers consider themselves, whether people who provided daily care to patients, those who were feeding them and dressing them and toileting them and helping them move, whether those workers consider themselves to work in a team. Whether physicians who work with those patients and nurses and licensed practical nurses and CNAs and social workers consider themselves to work in a team. So we did a survey. The survey was in New York State. There were 372, in this portion of the survey, there were 372 administrators and directors of nursing who reported, and 3/4 of them reported presence of formal daily teams. Now that was very exciting. We thought, wow, that's very impressive, right? And so we asked them further why they thought, what was important about teams. So almost 90% said because they promote quality of life, because they promote clinical quality of care, because they maintain good staff-resident relationships, because they reduce turnover and promoted retention. And so this was all going in the direction as we expected, as we knew about teams. But we then also asked nursing home workers, not just managers. So nurses, CNAs, physicians, social worker, therapists, chaplains, if they work in teams. And we asked them if those teams, how those teams were organized. Were they mandated by or promoted by management, or were they self-managed? So we surveyed over 7,000 respondents in 162 facilities, and about 16% of workers reported themselves as working in daily practice teams. About half reported to be formally organized, and half self-managed. So the penetration was certainly not, of teams, was certainly not as high as the management seemed to believe. And while there were only in 3 facilities workers did not report themselves in teams at all, 20%, half reported prevalence higher than 20%, and none reported penetration above 44%. So a lot of variation, but certainly not at the level that the managers imagine it. So that just sort of shows you, depending on what the question is, you might need to ask the audience that's more in the trenches. Okay, we then moved to ask, to pose the following hypothesis. We hypothesized that nursing homes with higher perceived work effectiveness will have fewer deficiency citations. That's a measure of quality in nursing homes, all other things being equal, all other factors with regard to case mix and facility factors. We also posited a hypothesis that nursing homes with higher prevalence of daily care teams will have fewer deficiency citations. Now, all nursing homes annually have a survey conducted by the Department of Health. That's a federal law, but it's done at a state level. And there are over 190 deficiency tags that a nursing home could be dinged on. And those deficiency tags relate to quality of care as well as to a whole bunch of other factors. So what our study showed is that nursing homes report where staff reported higher perceived work effectiveness had 22.4% fewer per facility deficiencies with regard to quality of care. They also had 22% fewer quality of life deficiencies, and they had 46% lower risk of deficiencies. This is teamwork. And they had 46% lower risk of G through L deficiencies. These are highest severity deficiencies where patients are at immediate risk or jeopardy. So very large effects that we are seeing with regard to perceived work effectiveness. We ask then, well, okay, so, but does it matter what the penetration of the team is? So we ask, does it matter whether there is a team, and does it matter whether teams are self-managed or formal? And we found that self-managed teams resulted in fewer quality of care deficiencies. We did not find similar relationship with quality of life. There are many fewer quality of life deficiencies than quality of care, and the G through L are very rare, so that may be why. But we didn't find a relationship with formal teams. One could expect that formally organized teams receive support from the management and resources, that they would be able to function better and be perhaps more effective in improving quality. But it's also possible that formally organized teams are more mechanistic, that their structure is more mechanistic, that the roles are very pre-specified, and that will be stifling. And as a result, that because they are so more hierarchical in decision making, that information is not going to flow down effectively. And maybe that's why we're finding these more organically structured self-managed team as being effective with regard to patient outcomes and not the formal teams. We also wanted to know whether having teams matters not just with regard to patient outcomes, but also with regard to cost of operating a nursing home. And so we estimated the cost associated with formal and self-managed daily practice teams. And what we found is that team penetration, that cost decline was increasing penetration of formal teams. Here we found the relationship with formal teams rather than with self-managed teams. And so you can see a decline here up to about 13% penetration. And here both the numbers begin to be scarce, but also we found that in this upward region of the curve, where costs begin to go up, the formal teams were much more diverse, and they had a larger number of participating disciplines. So perhaps there is with more complex teams in certain environments, such as nursing homes, you begin to lose the efficiency. But overall, we found a net savings of about $175,000 per year. That's not enormous, but in nursing homes, that is not insignificant amount of money. Okay, we moved a little further, and we also examined the association between staff cohesion and risk-adjusted pressure ulcers and incontinence. Risk-adjusted pressure ulcers and incontinence are fairly prevalent in nursing homes. On average, in New York State, the prevalence of pressure ulcers is about 15%. They are very bad things to have and lead to a lot of other very negative outcomes. And incontinence is at about 50%. So a lot of incontinence, and incontinence can be dealt with. So the question was, do nursing homes where staff have more cohesive relationships have better measures of risk-adjusted pressure ulcers and incontinence? And what we found was that in an average facility, one standard deviation, which was 0.23 increase in staff cohesion score, was associated with 4.2% lower odds of pressure ulcers and 7.6 lower odds of incontinence. Again, not insignificant, well, they're statistically significant, or I wouldn't be showing them to you, but they are also clinically very meaningful in terms of the magnitude. We also found that self-managed teams were important with regard to lowering pressure ulcers, so higher penetration of self-managed teams, lower likelihood of pressure ulcers, but not of incontinence. I'm going to skip this because I think I'm running out of time. So just to summarize, there clearly is empirical evidence to suggest that better teams and better teamwork do result in improved outcomes. One could ask, well, what about a gold standard? You know, the gold standard is always the randomized controlled trial. Somebody just recently alerted me to this study, which I thought was important for me to tell you, but there actually is a study that was published in BMJ in 2003. It was a study titled Parachute Used to Prevent Death and Major Trauma Related to Gravitational Challenge, a Systematic Review of Randomized Controlled Trials. And this study concluded that parachutes reduce the risk of injury after gravitational challenge, but their effectiveness has not been proved in randomized controlled trials. So, you know, we could accept that there is enough evidence based on observational studies that there are potential benefits of good work relationships and that they do translate to good patient outcomes, or we could be in a search for perhaps the Holy Grail and wish to proceed to first test it all with randomized controlled trials. So how can organizations strengthen teamwork or relational coordination? There are many effective ways. There are many tools. We know from high-performance work systems that it is possible to select for teamwork and that people should be selected for teamworks. It is certainly possible to train for teamwork. There are actually tools that exist for teamwork training. We should and are capable of measuring team performance. We can resolve conflicts proactively. There are tools for doing that. There are ways of investing in frontline relationships, designing job for a specific focus, etc., etc. And all of those have now been shown in through empirical evidence to improve communication and coordination and improve relationships between workers, which in turn impact quality performance as well as efficiency performance. So I think I will end with that, perhaps just to tell you that my colleague Dana and other colleagues in Rochester have recently been funded by the Patient-Centered Outcomes Research Institute, PCORI, to test the effectiveness of palliative care teams in nursing home. Guess what? Using the randomized control trial. So we are in pursuit of the Holy Grail, and we are looking forward to conducting that randomized clinical trial, and I hope to have an opportunity to come back to California to tell you what we find, but I expect better weather.
So we have time for a few questions. I have one, so maybe I'll ask. At the early in the talk, you showed some of the, I think, 3 points where people express, I guess I would say, dissatisfaction about how the teams actually work, and you used it to introduce some of the questions. So I think there were like communication problems that don't go well. Maybe 41% expressed those things. So it seems to me that there will be a big difference in how people perceive the functioning of teams, whether teams are assigned to individual patients or they're given a group, or they have to deal with all of the patients on a particular topic. So it wasn't clear to me that in addition to the issues with who is a member of the team, the responsibility of a team, patient-based or function-based organization. Maybe you could clarify.
I think this is subject to further studies. I don't know that one has been shown to be better than other. In our survey, we asked people if they were on a team. We asked them if their team was self-managed or mandated by the management. We asked them about who is on the team. We asked about specific professions, specific disciplines that were on the team. We asked if they actually had team meetings and how often. We did not actually look at that specific level of how team is organized with regard to outcomes. So I can't answer that question.
Yes.
Sorry, my question is about the ethical aspects, because if we want to do a randomized control trial on the subject, at least we have to keep a group of patients away from the teamwork. So it's ethical to do that.
Well, that is, we continue to, it's a good point. I have a colleague in palliative care center where I work who is very hesitant to conduct, for example, any studies that use a randomized controlled trial, even though there have been no studies showing that palliative care teams are better than no palliative care teams. There is no evidence. But that aside, the study that we are going to be doing is at a nursing home level. So it's not that we are, first of all, there are no, if you are asking me about the study that we are going to be doing, so there are no palliative care teams in nursing home. They don't exist. We don't know if they are better, worse, or indifferent. We have no idea. We think, based on this body of evidence and others as such, that if teams in general are better, then teams in palliative care would be better too. But we don't know. And we're randomizing nursing homes, not patients. So patients, it's not that a patient in a nursing home X, one patient is going to be denied while one patient will be allowed.
Okay, well, we have a little, we know that the pandemic flu is...
I have one more question.
One more question, I'm sorry.
I was thinking,
Yeah.
so I heard measurement and relationships coordination. But maybe because of your title, I'm curious how how the policy goes into the study, like where the policy like going in this study relate to patient outcomes. Can you talk about
What are the policy implications?
Yeah.
Okay, I skipped that slide. I do have it, it's in the end, and basically, I think there will be first of all, there are a bunch of challenges going forward. So one challenge is at the management level, and then what are the most, what are the best tools that one can use then to implement teams and teamwork. And one of the suggestions was that these team steps models are now available and could and should be tested more widely so that's basically the manager saying, yes, we want to commit to improvement, and we are bringing those tools and the experts with those tools into the nursing homes. Certainly, I think it will take commitment and continuity and persistence on everybody's part. It's as we demonstrated, it's not enough that the managers believe or want to believe that teams are good and that they exist. They really need to measure and say, is it just in our imagination because we think it's great, or do the staff, frontline staff, also view it this way? So, commitment, continuity, and persistence. The policy challenge will be that healthcare is hierarchical, and those both hierarchical and turf-oriented. So, social workers and nurses are fighting for turf, physicians and nurses are fighting for a hierarchy, and we need to continue. We've been working on this for a very long time and breaking those barriers, and I think things are getting better, but they may take more work. I think that we might need more payment models, or might need some payment models to promote teamwork. And to a large extent, ability to invest in teams is going to depend on the availability of staff and time. Staff and time is money, so if we can promote payment models that will make this attractive, managers might respond differently. The opportunities, I think, with the health reform and the accountable care organizations, the opportunity to actually promote teamwork seems to be naturally built in. Pay for performance models, payment models would allow teams, and budget, and global budgeting would allow teams, managers to actually be more flexible, at least, about investing in teams. So that was my last slide. Thank you for asking.
I think that developing team-oriented programs in the nursing field is definitely something important and effective, but implementing them is, I imagine, difficult. But could you comment on sustainability? What are some of the key factors in sustaining programs of this magnitude? Because you can do the work, and then once the funding is over, what happens then?
It's $1 million question. What happens then? In the intervention study that we haven't started yet, but plan on starting, we are actually providing information. We're not paying nursing homes because, in large part, first of all, we are prohibited from paying them. We might be tempted to pay them, but we are prohibited from doing that. So we're providing the tools, and we're providing the knowledge. The rest is really up to them. It may be possible that through report cards that are published so CMS publishes a whole bunch of report cards on hospitals, on nursing homes. Right now, there are no report cards on end-of-life outcomes. Actually, Dana and I work together on developing end-of-life outcome measures. Perhaps if those are posted, or if there is more evidence that good quality of care comes from good working relationships, maybe there can be something posted about good working relationships, and that will motivate managers to act differently. But sustainability is going to be a problem. It's a matter of persistence and commitment.
If I can add to that, if you remember the slide about the impact on costs, obviously there are effects of teams that are in the interests of the organization.
Right.
So it's a matter of bringing that information to, first of all, understanding more, because much of it is still a black box. We don't really know what it is about the team that generates those cost efficiencies, so we really don't have a recipe that we can give to a manager and tell him, you know, if you construct this team, you'll save X dollars.
Yeah.
But if we could get to that point and sell it to nursing homes, I mean, that would be a way to sustain it, right?
Yeah.
And I guess the other piece that is missing is, and it's sort of, I mean, it was really nice for me to sort of sit here and hear all of this, because what jumped at me is that different type of teams seem to be having an impact on cost, for example, than the type of teams that have a good impact on quality. That might be an area that we need to understand better. Because you really want to have an impact, you want the same team to have an impact on both.
All right, any other? Thanks to Dana for the final thoughts, and thank you so much
Thank you.
for visiting with us and giving an excellent presentation. This is a token for fighting the flu. It's a little spray as you go on the plane back. Thank you.
Thank you.
Thank you.